Welcome to the CREOG video project. In this video, we'll be discussing primary amenorrhea. Let's dive in. There are 5 major goals for this video. The first is to determine when to initiate a workup for primary amenorrhea. The second is to review the workup and differential diagnosis by physical exam, ultrasound, and lab findings. The third will be reviewing some of the differential diagnoses. We're also going to go through some quick associations or high-yield facts that should be helpful for the CREOG that actually just focuses on quick associations between the diagnosis and then either a treatment or physical exam finding. And then finally, we're going to go through a practice question and kind of pick apart the incorrect answers. So there are 3 major categories according to the ASRM about who needs a workup for primary amenorrhea. The first, and this is definitely the one to remember, is all females greater than 15 years old without menses. The other 2 categories are within 5 years if breast development before 10 years old, or if no breast development and greater than 13 years old. And most of this is based off the fact that at these cutoffs, you're greater than 2 standard deviations from typical puberty. Okay, trying to think about a way to remember when to do workup for primary versus secondary amenorrhea. So for primary amenorrhea, you can remember 5 for primary. So when you're greater than 15 and no menses, or within 5 years of breast development if you're less than 10. And then if you're thinking about the number 3 for secondary amenorrhea, it's workup within 3 months without menses or missing 3 cycles in 1 year. Just a potentially helpful way to remember and separate the 2. So whenever you're thinking about etiology for amenorrhea, you have to remember the vast majority of causes are due to pregnancy, lactation, and menopause. 97% of them, according to ASRM. And the remaining 2 to 3% are what we're going to actually talk about today. So 4 of those major conditions include PCOS, hypothalamic amenorrhea, hyperprolactinemia, and ovarian failure, also known as primary ovarian insufficiency or POS. Okay, now onto the workup. So physical exam plays a key role here. Whenever you're approaching a question, the major things to consider are breast development and secondary sex characteristics, in addition to presence of female external genitalia. This will help eliminate many of the answer choices. So when you're going through these diagnoses and doing practice questions, really pay attention to that differentiation. Other important lab findings include FSH, TSH, and a prolactin. And of course, your urine pregnancy. If that's honestly ever an answer as to what's the next step, that's probably going to be the correct answer. Okay, so there's a bunch of different ways to break down all of the differential diagnoses here. I think this one makes the most sense to me, but there's a bunch of other ways to think about this. So the first category is structural. So if you don't have the necessary structures or there's a deficiency causing an abnormal structure, you won't have menses. So starting inferior and then moving superiorly. Inferiorly, you'd have things like an imperforate hymen, transverse vaginal septum, even cervical stenosis or Asherman's, which I think sometimes I don't put in this category as much. I put that more in a secondary amenorrhea, but it could cause primary amenorrhea given, patient's history. Other things include Müllerian agenesis, which is also known as MRKH syndrome. And then here you can also think about androgen sensitivity, where you have this partial or complete inability to respond to androgens. And so you'll have, a patient with XY chromosomes, classically presenting with female external genitalia, and primary amenorrhea without a uterus. Second category is ovarian or gonadal. So this is where you have gonadal dysgenesis, either XX or XY. And you also can include Turner syndrome here, where you get streak ovaries. Also in this category, you can include gonadal dysgenesis, even if it eventually recovers from radiation or chemotherapy. And you can also put ovarian tumors in this category as well, altering proper ovarian function. This third category is the largest and kind of hardest to wrap your head around, but it includes endocrine and kind of systemic causes. So you can think of these diagnoses once you've considered or really thought that it's not structural or it's not ovarian or gonadal. This includes things like constitutional delay in puberty, Kallmann syndrome, which is also called hypogonadotrophic hypogonadism, and they'll often put that actually on the test rather than Kallmann, since so many people are familiar with Kallmann. Or there's a failure in the migration and ultimate development of the GnRH cells, leading to anosmia and delay in puberty or amenorrhea. You'll often find on the exams they will not put lack of smell as a sign. One, because most people wouldn't present with that symptom, and two, it's kind of a very easy pathognomonic for this diagnosis, so they often will actually take it out. Other diagnoses in this category include PCOS, congenital adrenal hypoplasia, prolactinomas, or other autoimmune inflammatory diseases that would inhibit normal GnRH or FSH and LH release. We won't be discussing every diagnosis here since this is, such a huge category, but this is another way of thinking about all the different diagnoses you can have. So if you go to this first box here, this is looking at breast development. So all of these patients will present and will have breast development because all of them will have the presence of estrogen. Here in the second category, these will not have breast development, but they will have a high FSH, right? So that's how you can kind of zone in on the fact that it's a gonadal etiology of some sort. And then finally, in this third category, it will have varying FSH levels, but typically no breast development, or will have some breast development. This, again, is kind of the variable category. Okay, this is a table of some quick associations and facts to go over. So starting with Müllerian agenesis, they'll often ask, what's the next step if they desire penetrative intercourse? The first step is always, always, always non-surgical with vaginal dilators, because in 90 to 96% of patients, they will be able to have a functional vagina, meaning able to have penetrative intercourse with the use of vaginal dilators, and hence surgery is not the first step here. There's also a bunch of techniques that they may mention regarding Müllerian agenesis if they do fail that initial vaginal dilator step. If this is something that you kind of want to really go above and beyond on the CREOGs, I would take a look at that as well. The second diagnosis here to have associations with is imperforate hymen with hematocolpos. Here you have bulging bluish mass at the introitus on physical exam. Ultrasound to confirm the diagnosis before you do anything. Once you've confirmed the diagnosis, the intervention is a cruciate or oval incision. For 5-alpha reductase deficiency, I want you to think male secondary sex characteristics but without hair, since you're not producing DHT, and no breast development. For 11 and 21 hydroxylase deficiency, they'll often throw these answer choices in to confuse you guys, and really what you want to think of here is this is viralization of 46XX. And then you'll also see potentially this as an option as well. It won't necessarily be an answer choice, but it might be, or it'll be an answer choice, but not necessarily the answer, is the SRY gene translocation. And this is when there's 46XX karyotype, but a male phenotype. And that's because the SARI gene has translocated onto the X chromosome. Okay, let's do a quick practice question. A 16-year-old girl presents to your office with her mother for primary amenorrhea. She reports breast development 3 years ago. She denies menstrual bleeding and is not sexually active. On exam, you note a small vaginal opening with a blind ending pouch. Tanner stage 4 breast development, Tanner stage 4 pubic hair. On abdominal ultrasound, there's no uterus. Her karyotype is 46XX, and her androgen levels are in the normal female range. FSH is 7.4. Which of the following is the most likely diagnosis? So the answer here is Müllerian agenesis. Let's go through why the other ones are incorrect. So for androgen insensitivity syndrome, the expected karyotype will be 46XY. For premature ovarian syndrome, also known as ovarian failure or premature ovarian insufficiency, this leads to an elevated FSH greater than 20. For PCOS, polycystic ovarian syndrome, must remember your Rotterdam. This is a huge testing point on CREOG, so just make sure you really feel comfortable diagnosing PCOS. Usually in the question stem, they'll talk about hirsutism or other signs of androgen excess. Also, no polycystic ovaries on ultrasound, and unless there's a concurrent diagnosis, you would anticipate a uterus in a patient with PCOS. Swyer syndrome is gonadal dysgenesis with a 46XY karyotype. Here you would have an elevated FSH as well. So for those two reasons, this is an incorrect answer. These are the references and resources. I definitely recommend going over the, there's a great CREOGs Over Coffee podcast. There's TrueLearn question, which is what that question I just went over is based off of. And there's also PROLOG questions related to amenorrhea that's located in the REI PROLOG. All right, good luck studying.